Welcome to this evening's seminar, What's Happening Next? Resuming Endometriosis Services. And I'm sure that you'll all join me in thanking the amazing team at the Royal Free who've given up their evening and a lot of preparation time, I know, to be coming with us to talk to us tonight. We're going to have three really great presentations tonight from the team. Mr. Fevzi Shakir is going to be talking about what's going to be happening, as far as we know, with resuming endometriosis services post-COVID-19. And then we've got a session from Dr. Arif Ghazi on endometriosis symptom self-management around pain management, and then Hannah Beecham will be talking to us about self-management of endometriosis from a physio perspective. And having seen the excellent video that Hannah's done, I'm very much looking forward to all of those sessions and that one as well. Just to do a little bit of housekeeping, if you have any questions, please could you put them in the Q&A section, and I see already if you already have in there as well. We thank you to all of you who sent in questions beforehand. We had a really great range of questions, and the speakers have tried to include those into their questions. I should add, we did get quite a few on fertility, and we're looking to actually do a separate webinar on that as well, because there's quite a lot that people want to go into detail, so we are looking to do a separate webinar on that as well. And just one last point for housekeeping, for questions, can you please try and keep questions as general and applicable to others as possible? We aren't going to be able to answer any specific medical questions. And on that note, I would like to ask my panelists if they could put on their videos, if that would be great. I'm hoping that will work nicely. So hello Fevzi, how are you?
Hi, very good, thank you, Emma.
Hello everyone.
Hi everyone.
So I'm going to, I do get asked sometimes why Fevzi is a Mr, not a doctor. So I'm going to let you explain that, Fevzi. If you could introduce yourself, that would be great, please.
I'm Fevzi Shakir, consultant gynecologist at the Royal Free, and I specialise mainly in advanced gynecological endoscopic surgery and especially endometriosis. I'm also part of the British Society for Gynecology Endoscopy, an elected senior council member on their in charge of website, and one of the medical advisors to Endometriosis UK, and it's great to be here this evening to talk to you all.
Great, thank you, Fevzi. Arif, would you like to introduce yourself? Oh, you're on mute, Arif. Could you come off mute, please?
I'm sorry. Thank you, Emma. My name is Arif Ghazi. I am one of the pain consultants and the clinical lead for the services at the Royal Free Hospital. I have an interest in working with my Fevzi and the colleagues in pelvic pain. And although I'm speaking to you today, I work with the whole team. And so the real theme of my talk is about the different range of options that we can use using different team members to try and help with pelvic pain.
Hi, I'm Hannah. I'm a specialist pelvic health physiotherapist working with men and women experiencing pelvic pain and bladder and bowel symptoms. I really enjoyed speaking at your last information day, so thank you so much for having me back to talk this evening.
Hi, good evening. My name is Gonzalo. I'm a senior clinical fellow working at Royal Free Hospital. I have a special interest in laparoscopic treatment of endometriosis, and I will try to answer as much questions as I can today.
Sorry, I was on mute then, wasn't I? Sorry about that. I've done that one now. So Gonzalo will be answering questions on the Q&A. as we go along, and I think that's probably the hardest job that everybody has, so thank you on that one. And I'd like you, before I hand over to Fevzi, just to introduce you to one of the other members of the team, which is Nicola. Are you going to say hello, Nicola? And do you need to unmute as well? We're all doing it now, aren't we? Yes.
Hello there, hi, I'm Nicola and I'm the specialist nurse for endometriosis at the Royal Free Hospital, and yeah, work with the amazing team, and yeah, very much looking forward to tonight. And
Thank you, Nicola. So I'm going to, without any further ado, hand over to Fevzi, who's going to take us through the first session, and the rest of us will put our videos off. Thank you.
Is that all on? Everyone can see that, I presume?
Yep.
Yeah, great. Well, good evening, everyone, and thank you very much once again for joining us in this session, where I'll be primarily talking about resuming endometriosis services, and some of those have been resumed already, and some of them actually never stop. But I'll give you a little insight into what's happening at the moment, and obviously it's an evolving situation, so things may change as time goes on. But what I'd like to talk about this evening is really our outpatient services, and a little bit about how we have to now prioritise some of the cases that we see in outpatients and what's been happening with that service. Although we've been hearing a lot about coronavirus in the media, and I'm sure you all know a lot about it now, I want to talk a bit about it, in particularly to the risks of surgery, because I know a lot of patients are anxious about surgery, and really trying to answer some of those questions and what risks are involved. And also how we're mitigating the risk of surgery, because we have actually started doing surgery again. And last week I did some endometriosis cases last Tuesday, and this Wednesday I'm doing some complex endometriosis cases involving the bowel. So we are starting again, and there are certain things that we have to try and do to mitigate that risk. And again, I stress that it is an evolving situation, so things can change all the time. But I think it's important that you're aware of what's happening now and what things will look like in the future. I'd also want to talk a little bit about prioritization for surgery, and this has been really directed from all the specialist societies, not just in gynecology, but also in every single specialty, in collaboration with NHS England. And then a little bit about logistics and advice if you are actually going to go for surgery, what things you'll be expected to do, what that pathway will look like, because sometimes you can be caught unawares if you get a call inviting you to have surgery, or your position on the list has come up, and it might be a few unexpected things. So I thought it was important that you're aware of what we're currently asking patients and staff to do at the moment. So in terms of outpatient diagnostics and prioritization, well, really our clinics never stop, but they did change. They changed dramatically in March from me seeing 40 to 50 patients in total a week to suddenly seeing hardly any, or just the emergency cases on a face-to-face basis. And we're now conducting a lot of our consultations either through media like this, through Zoom or Microsoft Teams, or via telephone, and we can obviously have remote access wherever we are. And it's quite interesting doing this process, that there is quite a lot you can achieve from someone's history, and also from any diagnostics or imaging that they may have had, without having to see them face to face. But of course, if we have to see face to face, that is something that's still possible, but we obviously want to limit the footfall coming into any hospital at the moment. So in terms of emergency outpatient, or things that we have to see, these are conditions which, most of the time would come through the emergency department, such as a pelvic abscess, for example, or if there's severe anemia from bleeding, and those things have to be seen almost immediately or very, very quickly. If there's any post-operative complications or issues, for example, we're encouraged that we have to see patients quite quickly again within 7 days. And one thing I just want to stress about these timelines is that these timelines are ideal timelines. Sometimes, we would really want to see patients quicker than that, but they're really for prioritization purposes, and equally, due to the volume of patients, we're not always able to see patients within these timelines, but nonetheless, we have to put them into some sort of prioritization to get through the waiting lists that we had prior to the lockdown. So within 14 days, again, this is a guide for suspicious cancer or severe endometriosis pain that may not be controlled with any other means. And again, this is a guide, and I know from my patients, it's not always possible to see people within 2 months, let alone 2 weeks. But again, these are important for prioritization. And then most patients will fall under, within the 30 days or over 30 days. So these are things like bleeding with anemia, severe pelvic pain with a normal ultrasound scan, and then over 30 days, most other pathology. So a lot of endometriosis cases will probably fall within the 30 to over 30 days. But again, I stress, it doesn't mean you're going to be seen in that time. It's just how we need to try and prioritize patients into forming some sort of order to see people in. And again, there are individual cases, there are exceptions to all of these things. This is just a guide to try and fit most people into. But in summary, we are really taking referrals as normal. It's just a different way of seeing people, and I'm sure some of this will continue even after coronavirus is all finished, and some of it will be a more efficient process. And I think some good can be taken from the negative things that have happened with coronavirus. So a little bit about the virus and where it's been isolated, in particularly in relation to surgeries, what I want to focus on. So we know that it's been described in several sites in the literature, mainly the respiratory tract, which is where most of the spread can occur, but it also is found in the blood of some individuals. We know it can be found in the whole gastrointestinal tract, in peritoneal fluid, and in semen in some studies. Thus far, it hasn't actually been found in urine or in the female genital tract. And that's quite important in that it's reassuring for staff and colleagues which work with gynecological patients, because where some of the areas that we examine, or some of the areas where we'd expect some pathology to be, haven't isolated coronavirus in those areas. Now, as well as droplets, those are obviously the big particles that are expelled when one talks, or there'll be some droplets when you cough or sneeze, for example. Those big droplets are usually protected by things like masks, or even if you stay a certain distance away from someone, you'd expect the large droplets, because they're quite heavy, just to drop to the ground and wouldn't go into someone's face to actually contract coronavirus. But what we do worry about is the process of aerosol generating procedures. So these are the AGP, so the aerosolization, and those are the smaller particles. And again, you get tiny small particles when you cough or sneeze, but in particularly also during intubation. So when the anaesthetists anaesthetize you for an operation, and they have to give you oxygen, and then the tube is passed to control the breathing during the operation, that process can release a lot of these little aerosols, which can fill the whole atmosphere of the operating theatre. And that's where some of the issues have arisen initially in terms of spread and controlling coronavirus. So that's why we all have appropriate PPE in the theatre environment. But also why, and I know there were some questions sent with regards to this, as to why laparoscopy may also be an issue. And some specialist societies advocated halting or stopping laparoscopy for the time being. Not the gynecological societies or the BSG, but some of the general surgical societies. And that's because if you expect there to be some coronavirus in the peritoneal fluid or in the gastrointestinal tract, where general surgeons or colorectal surgeons do bowel surgery, then as that gas is released from the pelvis and the abdomen through ports, or when the gas is released at the end of the procedure, you can get aerosolization of those particles. And if some of the particles have some coronavirus within them, then that's the risk that some people are worried about. But again, we'll come on to that, but it's not found, thankfully, as much in the blood. And even if we're doing complex bowel endometriosis surgery, it's not found in all parts of the bowel, and there are ways of mitigating that risk, which I'll come on to. So I'm quite comfortable personally doing laparoscopies at the moment, and I've done them and will continue to do so, as long as some of the mitigating steps that I'll talk about are adhered to. Now, a lot of people worry about coronavirus, and it is a very serious condition, and the most serious aspect of it is its mortality risk. And we know that that's age dependent, and this is data just from a general population. Obviously, there's several factors in here, but it's everything pulled together. Now, what people are interested in, and indeed what I was interested in as well, what's that increased risk if someone has surgery? Is there additional risk, and what is that risk? So quite recently, this is one of the largest studies that was published just a couple of weeks ago, actually, in the Lancet. And this looked at 1,128 patients worldwide in about 48 countries from surgery that took place from the 1st of January up to the 31st of March. Now, what's important to realize is this is a collective group, okay, of all men, women, all surgeries, all different medical problems, etc. And there is definitely an increased risk if you do contract coronavirus during surgery, and the risk of mortality in this series was 23%, and the risk of having any pulmonary complications was 51%. But that risk is definitely lower for women than compared to men, and we know that that's 28% compared to 18%. And of course, if you're older, over 70 group, then again, that risk is higher, of 33% compared to 13%. And again, if you're having emergency surgery compared to elective surgery, the risk is higher. So generally speaking, our cohort of patients in the endometriosis group are generally, of course, there are exceptions, in the younger age group, with, who are women, obviously, and are having elective surgery. So the risks are significantly lower in that age group, which is reassuring. And there are other things that we can do to bring that risk even further down. So the risk factors that were found from that study were, obviously, if you're male, over 70, if you're having surgery for cancer, emergency surgery. Major surgery was a risk, and some endometriosis surgery is major surgery, especially if you've got bowel involvement or anything more significant in terms of dissection, etc. High anesthetic risks, these come down to past medical history. So, those patients which may have cardiac or lung problems, or in the group of patients that have thoracic endometriosis, these things probably pose an additional risk which has to be individualized. And whilst the paper didn't look at the BAME cohort of patients, we obviously know that there is increased risk in those groups as well. So how do we mitigate the risk? Well, what we're currently doing is we're trying to obviously perform surgery in COVID lower risk areas. Now, each hospital will do that slightly differently. So if a hospital has multiple sites, okay, if the surgery can be performed in a site which doesn't have many cases, they'll tend to do that, but sometimes the high risk surgery has to be done in the bigger hospitals where there are emergency departments, etc. But where there is those situations, COVID lower risk areas are being produced in the hospital. The flow is designed in such a way that they're not mixing the patients or mixing the staff as much. The other thing that you'll notice is that if you've been called for surgery, we'll ask you currently to isolate for 14 days before surgery. Now that's the whole household, and isolation literally means you don't leave the house for exercise, for shopping, for anything. So all of those things have to be really addressed beforehand. So if you do get a call for surgery, if you're on the waiting list, these are some of the things which you'll have to be prepared to do prior to the surgery. And it's really important, and I'll explain to you why that is as the talk goes on. We'll expect you to have a negative antigen test 48 to 72 hours before surgery. I'll put that time frame in because every hospital, again, is slightly different. So we will swab you, that's the swab test, to check that you currently do not have coronavirus. We're also putting all patients into single rooms, not in the open ward anymore, because again, we're trying to create that COVID low risk area, again, to lower the risk to you and everyone else as much as possible. Unfortunately, there's no more visitors to the hospital, both in terms of clinic appointments and really in terms of, post-operatively. So, again, we're trying to reduce the footfall as much as possible, and that's something that's been echoed not just in the UK, but in several other countries as well. And like I said, the flow through the hospital will be managed. It's not perfect as yet, but it is continuing to get better and better as time goes on. Obviously, as staff, we'll all wear appropriate PPE in the designated areas. We'll have temperature checks and again, health screens as well. In terms of laparoscopy, we've always, I've personally always used filters in terms of filtering the gas that comes out of patients, not only for aerosols, but also, in terms of any energy that you use or smoke, it's always good to filter those through a filter so it doesn't go into the atmosphere. But there are newer ultrafiltration devices which a lot of hospitals have or are acquiring in order to reduce that risk further and reassure people that laparoscopy is safe. Now, one thing I just wanted to share with you, that this isn't a published data, but this was centres in London which were continuing to operate during the coronavirus peak, if you like, because they had to in terms of cases for cancer, and certain sites were used in London. And this was done in other parts of the country as well, but I knew some of the London data that I wanted to share with you. And they operated throughout the pandemic of about 500 cases. Now, initially, before all the testing or the antigen testing was widely available, only questionnaires and 14 days isolation was done. And when that was done, 11 cases of coronavirus were detected, okay, of that 500 initially. And that equates to 2.2%, which is about what it is in the community in terms of asymptomatic individuals carrying coronavirus. It's about the same in the community, about 2.4% that we know. Now, when antigen testing was regularly instigated more recently, there's been no cases that have been identified of coronavirus during any of these operations. And these are, again, much higher risk individuals than you would be for surgery. And there were no deaths in this group as well. So personally, I am reassured that it is safe to reinstigate surgery, and that's why a lot of places are doing that. And the other aspect is viruses will always be around, and we have to work around them and with them. And these are good measures which should be taken anyway, even after coronavirus. Now, obviously, there's a big waiting list for a lot of surgery. And I remember reading an article that they said there's going to be millions of cases waiting currently for surgery. And there has to be, again, a way, a bit like the outpatient clinic, of how we prioritize our surgery. Now, priorities again have been done for all the specialties in a similar type of way, but with their own unique nuances. So for example, for gynecology, an emergency surgery, one that is what we call priority 1A, is something that has to be done within 24 hours, and it's always done within 24 hours. For example, ectopic pregnancies, twisted ovaries, ovarian torsion, or intra-abdominal bleeding for any cause has to be done irrespective of the risk, because the risk of not doing it is so detrimental. Priority 1B is within 72 hours. Again, these are without question. They have to be done because patients can deteriorate if they're not done. Priority 2s, these are cases which should be done ideally again. And again, I stress that these are ideal times. Again, we want to do them as quickly as possible, but in reality, we may not achieve these times. But for a priority basis, we have to put them in priority. And this could be something like suspected cancer, for example, or of the endometrium as an example, because treatment can be instigated even without surgery beforehand. Now, in terms of most endometriosis, that will tend to come under priority 3 and priority 4. Priority 3 would be something like severe endometriosis with organ involvement, no relief from medical management. And most other laparoscopies would be priority 4, i.e. they could wait till over 3 months to be performed. Now, again, a lot of the times these were, most people waiting over 3 months, irrespective of coronavirus. But again, as a priority basis, we have to prioritize patients. So there may be slight changes in the order that you may have been if someone, with a suspected cancer, we saw recently, for example, that may jump the priority queue understandably. But most people will be in the 3 and in the priority group 4. And again, we have directives that we can start operating on these patients, but of course, every single specialty has to go through their priority 2 first before we can move on to a priority 3 and a priority 4. And as an example, where in Royal Free, we're operating with 19 theatre lists a day, and 2 of them may have been emergency and the other 17 elective. We are now gone down to 2 elective lists. So it's a dramatic drop, and that's not because, there isn't the staff or any other reason, but we have to, figure out how we can do this in a safe way without causing that increased mortality. And with the current measures, it is quite safe. So there will be a gradual increase in our theatre capacity, but it will take a bit of time. And as we know, that things are safe and can be done in a controlled way. So a little bit about the logistics. Like I said, if you do get called, be prepared to isolate. You might get called at short notice, and you need to work out the arrangements with the household in terms of shopping, etc. Swab tests will be required, and a lot of hospitals, what they're doing now is a drive-through. So ideally, you should drive in your own car if you have one, have the test, and then go back home. You'll then be texted and contacted a few days before surgery, or day before surgery, to make sure that you're negative. Now, again, this is a little bit arbitrary, but from the data of the study, a lot of the mortality was looked at over a 30-day period. So logically speaking, if you have surgery, your immunity is a little bit down. So, you should really isolate at home as much as you can for at least a month after surgery if you can, because you want to reduce the risk of catching any virus during that critical period when you're recovering. But again, this is an arbitrary figure. Some surgeons even advocate more, but I would personally be comfortable with 30 days. And again, all staff are screened and temperature checked. So, that certain things can happen on the day. If I came in to do an operation, I had my temperature checked and it was, above a certain level, then I would not be able to do your operation. So there are certain things that can happen, and you need to be prepared for these eventualities. So there are possible cancellations that can occur, but thus far, all the surgery that we planned has gone ahead fine. So really, in summary, endometriosis services and all services really will change everywhere. Virtual clinics and telephone clinics will probably become normal. They'll probably never, they'll probably never stop, and that they will continue in that manner. But obviously, we still have the capacity to see face-to-face if we need to. Surgery does pose an additional risk if coronavirus is contracted, there's no doubt about it, and it's important that you're aware of this. However, the risks have to be individualized between each person, but most can be mitigated. But obviously the guidance may change as the pandemic does. But currently I stress that I personally think it's safe for those individuals with low risk factors. And that's it. Any questions?
Thank you, Fevzi. That was very comprehensive and very clear. I think we're all just coming to terms with the impact coronavirus has had on so many aspects of life. And it is quite scary in a way to think just how many, there's a good several 100,000 operations that are now waiting that need sorting out, and it's really good to hear what the proposals are. One of the questions I've had is this applicable to the whole of the UK, or will it be different in different parts of the country?
So again, the prioritisation process is applicable to the whole of the UK. However, each trust, each hospital would have been affected, differently by coronavirus, and that they'll each have their own issues on local issues, and some hospitals have multiple sites, some hospitals will have single sites. But as a general rule, most hospitals are probably working on, a quarter of their capacity. So there will be longer waits, but the process is very similar, albeit slight nuances with each hospital and each site.
That's great, thank you. Now, there's been several questions about the issues of if someone has been put into medical menopause, something like ProStap. And Gonzalez, do jump in if you want to on any of these. And there's questions around if people who were, say, put on ProStap, they're expecting to be on 6 months, it's gone over that, what happens, should they do? And also people who'd stopped taking it because they'd gone over the length of time, but now their surgery is cancelled. Have you any suggestions for those, or who should they contact?
So again, the issues with ProStap, and the reason the 6 month comes into it is the risk of what we call osteopenia and osteoporosis. That's the main risks that we worry about. So osteopenia is where you have a demineralization of your bones, but it's reversible. When it gets to osteoporosis, it's irreversible. So we want to stop that process. Now, in actual fact, it probably takes realistically about 12 months, or maybe even more in some people, to get to that osteoporosis stage, but we never want to push it to the limit. So the BNF will always say 6 months, and that's what most people will be comfortable prescribing. Now, if you want to have a break from it because surgery has been postponed, then that would be one way of doing it, i.e., if you've completed your 6 months, stop. And then if surgery will be a number of months down the line, restarting it nearer the time. And that bit of break should give your bones enough time to recover a bit and not reach that period. But again, it's very individualized, and there are certain bone mineral density tests that we can do if someone is worried about that. But it is something that has to be individualized again, and will vary from person to person as to what's best. Some people like being on it because it helps their symptoms. Other people, they're just obviously on it because they'll require it pre-surgery, so they may not mind stopping it. So everyone's a little bit different in terms of how they respond to it.
That's great. And if people have specific questions, I presume they can contact their gynecologist or their GP, which would be the best place to go, Fevzi?
Absolutely, because everyone will have slightly different situations, and that would be the best
That's great.
way forward, really.
And we've had a question which is regarding the fact that COVID, Suzanne, I'm hoping I'm asking this question properly, regarding that COVID has more of an impact on men. If somebody is on something like Zoladex and it's reducing their estrogen, will they have other risk factors that are more likely to affect men with COVID?
So I don't understand what you...
So I suppose if somebody's saying is if I'm having, if my estrogen is being stopped with Zoladex, am I more likely to be at risk of COVID because I don't have female hormones?
It's very difficult because no one knows the exact reason why females are less affected than males. One of the theories is the fact that some immunity is X-linked. Obviously, females have two X's, men have an X and a Y. So that's one of the theories, but there's probably other factors that play into it. So I don't think it will just, it will dramatically reduce your immunity towards this. But the best thing, obviously, is follow the advice not to contract, or to reduce your risk of contracting it in the first place.
That's great, thank you. Now, I'm just looking at the time. I know there are a lot of questions still outstanding. However, we have two other excellent speakers as well as Fevzi. So what I'm going to suggest we do is now move on to Arif, if that is okay. Fevzi, thank you very much for that. Okay. I know you're still around. And for those of you who've asked questions, we will try and pick them up as we go along and try and get answers to those as well. But Fevzi, if I can ask you to stop sharing your screen. And if we can welcome Arif. Oh, sorry, is it Hannah next? Have I got my orders wrong? No, it's Arif.
No, it's Arif, yeah.
Thank you. Arif, over to you.
Okay. Just share the screen. Okay, so thank you. I'm just going to scroll through my talk and I will try to integrate some of the questions that were forwarded earlier and leave some time at the end for new questions as they arise.
Arif, I'm sorry to interrupt. I'm not seeing a shared screen. Fevzi, are you seeing a shared screen with the presentation?
Okay.
Sorry, everyone who's watching. We're learning new skills.
I'm just, I have selected it.
Brilliant, thank you.
Okay, so let me just come out. Can I check? Are you able to see the screen now?
Yes, that's great. Thank you.
Great. Yes, so I will give an overview of really an insight as to what happens in the pain clinic, partly because although the specialty of gynecology is very widespread, the specialty of pain clinics, and certainly within a subset within that specialty of pelvic pain, is very much not very widely spread. And so part of it is to raise an awareness amongst the professional colleagues and patients of what it is we offer. So the first thing is, when should one refer to the pain clinic? Now, generally, it's the referring team are the gynecologists. So where there is an unclear diagnosis, or there are pending investigations, or indeed, whilst patients are on the waiting list for planned treatment, we haven't received the referrals. And historically, the advice was to wait until the investigations have been completed. My personal feeling is, actually, now that we're promoting a lot more collaboration and multidisciplinary team meetings, that's not necessarily the case. And I think we are welcoming earlier referrals, particularly as the investigations and the course of the treatment can span many years, particularly with recurrent episodes. So I think where it's important is to try and involve us early, to try and prevent the establishment of negative pattern of behavior. This is not new. I mean, certainly if you go back to 2012, IAS, which is the International Association of the Study of Pain, listed visceral pain as one of their main aims. And even internationally, there was a World Congress on combined abdominal and pelvic pain, where we have been trying to spread a similar message. There have been large collaborations trying to work on the precise definition of what exactly is it that we're talking about when we talk of persistent pelvic pain. And so the definition that I've put on the screen is really something that encompasses not just the pelvic structures, but certainly if you look at some of the common questions that have been raised by, for example, Roshni, this also does include an awareness that bowel symptoms are very common. This will come as no surprise to a lot of endometriosis sufferers that this is a very common condition and is being increasingly recognized, and there's a huge knock-on effect on daily impact and function and sleep, and a downward sort of depression on mood. So here I've highlighted a sort of a patient pathway where there will be, when patients are referred to us in the pain service, they will be initially assessed by someone like myself. I will have the privilege of working in a multidisciplinary team, and Hannah will be talking about the pelvic health side of things, so I won't try to repeat her talk, but I will spend a bit of time talking about what's covered with assessments from clinical psychology. And it's often difficult when we're looking at research, because pelvic pain, often there is an overlap in symptoms involving the bladder, irritable bowel, soft connective tissue such as widespread pain of fibromyalgia, and chronic fatigue syndrome. And certainly there was a question from Emma, and fatigue is certainly something that we commonly see, and not necessarily initially reported, but part of my assessment is to actually question further on these things. So often people think of us as someone right at the long end of a list after patients have had their symptoms for many years, have been thoroughly investigated by lots of colleagues. Within our service, we have consultants in pain medicine, usually with a background in anaesthetics. We have clinical nurse specialists, specialised pain physiotherapists, and specialised clinical psychologists, with regular input from other team members. I have borrowed some slides from my colleagues at UCL. These are from my colleague Natasha Curran. And so just to give an overview really of explanations, because often one of the things that patients are often struggling with is initially there is concerns that their fears are not adequately taken seriously. And so often the degree of the clinical condition of endometriosis, particularly at the early stages, may not necessarily be in keeping with the severity of the impact of the pain. And that can lead to an often a modified behavior of avoidance of any of the activities that bring on the pain, and often there is understandable concerns in terms of anxiety, catastrophizing, and hypervigilance, where people are often watchful and waiting for the effects of pain to come on. As you can imagine, this will have knock-on effects both on work, family, relationships, and often on fertility. This often goes hand in hand with depression. So a lot of people may be familiar with cognitive behavioral therapy and other treatments, and so often what is explored, usually in a one-to-one scenario, is trying over a series of sessions. Firstly, discussion of some of the concerns. I know that Catherine had asked a question about difficulty in sitting, and so this is a common theme, and so it's about graded exposure to sitting. Taught on how to cope with these often harmful and negative catastrophic thoughts. During the episodes of pain, learning mindfulness techniques to help refocus the attention. It's helpful to involve partners and family. There's often a link in terms of a history of sexual abuse, but the studies suggest it's not necessarily always the case, but certainly that's something that is covered in terms of one-to-one sessions where relevant. Often these can be wrapped up where appropriate in a pain management program, and often these are over a period of time, usually over a 6 to 8 week intensive weekly involvement, and then with follow-ups at 1 month, 6 months, and a year. I'm just going to move forward and past physiotherapy because this will be covered in the next talk. Now, I've covered the medications because often people have not been tried on things other than the usual simple analgesics, such as non-steroidal anti-inflammatory drugs and opioids. But often we are using medications such as antidepressants or anticonvulsants due to their combination of nerve activity suppression, help with sleep, and muscle relaxants. Generally, opioids are not used, and we advise on weaning them down, partly because they have a knock-on effect on constipation, which can often aggravate pelvic symptoms. I'm going to give an overview of some of the interventions that pelvic pain specialists often will use. And often these can be directed towards individual nerve blocks, sympathetic groups of nerves which cover a lot of the internal sensation in the lower abdomen pelvis, or neuromodulation, which is a term that encompasses invasive implants that are being used for things like chronic pelvic pain, and they have a use in incontinence. You can see from the next slide that there are lots of different areas that can overlap, and so whether they are visceral or soft tissue, abdominal pelvic pain, referred pain from other structures, for example the lower spine, ischemic and vascular pain, metabolic pain, and very superficial cutaneous pain, particularly in nerve entrapment syndromes after surgery. I've put a diagram which shows the difficulty in often pinpointing where soft tissue or visceral pain comes from, because there is so much overlap, and it is very difficult sometimes to establish the initial cause. I'm just going to go through some of these slides quickly because so the indication for some of the sympathetic blocks is really to cover endometriosis, some of the consequences of that, which might be the adhesions, and chronic pelvic inflammatory disease. And there are other non-gynecological causes that I've listed below. Those involving the bladder, bowel, and post-surgery, and lastly, those related to neoplasms or tumours. This is an example of how this might be done where the patient is lying on their front, and I will be doing this in the operating theatre under X-ray guidance. And the diagonal lines on either side of this image show the needle approach, and the horizontal darkened area in the centre of the picture represents X-ray contrast, which confirms my end point. I'm just going to move forward. Often people present with a variety of superficial trigger points, and these can be usually targeted with ultrasound guided superficial nerve blocks. Sometimes there are pain, particularly after surgery, and this can represent an entrapped nerve, or it could be, and it may mimic some of the other conditions. The other area is very much sacral nerve pain, or coccydynia, or pudendal neuralgia, and this can be related to either musculoskeletal causes such as sacroiliac pain, coccydynia, and even though there are a variety of causes, this is often felt in the same region. And this may be covered with a pudendal nerve block. And this is an X-ray image of how that block is done in a very similar way. This can also be done under ultrasound. I'm just going to move forward through that. For a very localized indication, a ganglion impar block, which is another version of a sympathetic nerve block, can be done. Lastly, I have mentioned spinal cord stimulation. This is a very specialized treatment, and this involves an implanted lead, which is rather like an epidural connected to a neurostimulator or a battery. I'm going to spend the last couple of minutes of my talk just briefly summarizing clinical psychology. I've borrowed some of these slides from my colleague Amanda Williams at UCH. Now, a significant part is involving explanation, encouraging sort of patterns of self-management and psychological pain management. Looking at studies of women with pelvic pain, a lot of the distress is centered around concerns of what's wrong, and there's been a lot of reporting of the communication, a dissatisfaction with the explanation, and often because they have seen so many different specialties, there's conflicting advice, and often that makes it very difficult to know whom to trust. Part of the aims here is really to try and give detailed explanation, but also to help improve the control of pain, and to try to work towards long-term goals by graded steps. That in turn will help to reduce some of the attendant distress. So the key thing here is it's important to address some of the negative behavior and try to unravel some of the unhelpful beliefs. So really, just to summarize these clinical psychology, spending some time really trying to get a better understanding of patients' understanding and perception is crucial in terms of compliance with the treatment and long-term success. trying to really address the individualized causes of distress will help with how we can work with individuals moving forward. I'm just going to stop there because I just want to double check if can I just give you the opportunity for questions, Emma?
Yes, that would be great, Arif. Thank you. So we do have a few questions. Thank you for that. I think, Arif, you could do an entire session just on pain management, and I'm sure we'll get asked to do that next. One of the questions people have is that so if people are waiting for surgery and are in a lot of pain, do they go to their GP for pain management, or should they contact their specialist centre or gynaecologist?
I think the easiest thing to do, particularly when we're discussing a multidisciplinary specialist centre like the Royal Free, is I accept direct referrals from my gynae colleagues who are able to actually express the urgency of how soon they would like the patient to be seen. Because at the moment, we are struggling with the interruption of services because of coronavirus. And what we've tried to do as we are re-establishing the service is telephone or attend anywhere type video conference calls. And so my answer is I would ask for a consultant direct referral from either the gynaecologist or from the GP. I have a very close working relationship with local GPs. Okay, that's great, Arif. And I know that Sarah is having problems because her gynae team asked the GP to get her referred, and the GP wasn't sure because she could go to different ones. So I think you're saying that it might be better to go to get her gynae team to try and refer her if the GP isn't sure what to do. Is that right? Yes. Sarah, I hope that answers your question. So Arif, you mentioned behavioural therapy in your talk, and one of the questions is how often is mental health support offered, and I suppose how can people access that if it isn't offered to them? One of the strengths of the pain service at the Royal Free is we've collaborated with clinical psychologists who have direct sessions with our service. We work in collaboration if, for example, a patient has mental health input, to try and work with them so that, depending on the patient preference, certain aspects are covered within the pain service and other aspects are left with their mental health care team. One of the challenges has been that mental health services are very poorly provided depending on the postcode, and the way that we've overcome that is the Royal Free is we have clinical psychologists who are working within the service, and that's independent of patient postcode. In the past, and certainly at other trusts that I've worked at, it was very much dependent on either the postcode of the GP, referring GP, or the patient, and that had led to patchy service provision, but that's not the case at the Royal Free. Great, thank you. And we've had a couple of questions for you to go into more depth areas about certain things, which I'm afraid we are not going to have time for tonight. So for those of you who've asked, there's a specific request about correlation between pelvic pain and sexual abuse, and there's some other questions. We will pick those up, try and pick those up in future events. I'm afraid we're not going to have time to go into all of that at the moment. Yes, of course, Emma. Just on that topic, I did have about 3 or 4 slides on that topic, which I'm very happy to talk about on another time. That would be great. Thank you, Arif. I'm afraid we're going to be taking all your time, are we? I have another question. I'm not sure if this would be for you or Hannah, actually, but it's a question from Deborah about if a TENS machine relieves short-term pain, should you use it? Is it okay to use, or should you see your gynae team first? Is that for you or Hannah, Arif? I would be happy to advise the only contraindications to a TENS machine are if you have a pacemaker, any areas of cut skin, or if you're going to be in contact with water. So absolutely, these are a very useful adjunct to managing the pain, and it doesn't, not being related to medicines, it doesn't have all of the attendant side effects of most medicines, such as sedation and constipation.
Yeah. And we're having a few questions around how do I get referred to a pain team? And for those of you, you don't have to be in London. So any BSG accredited centre has to have access to pain management. So if you've got one local to you, you can try that. The Homerton do have one, Carly. So do see if you can get a referral to there. I'm just looking at the time, Arif. Did you have more slides you wanted to cover, or?
No, that's my
ask
summary.
a couple more questions then, if that's okay. Sorry, excuse me, one moment.
Just on the subject of referral,
Yep.
if there is a local pelvic pain centre, then obviously the patients should aim to engage locally, but we do, and I certainly do, accept out-of-area referrals.
Right, so that's great. And Vicky's asking, are pain clinics only available at BSG centres? They should be available more widely, shouldn't they, Arif, than just BSG centres?
I'm sorry, BSG?
Oh, so British Society of Endometriosis Specialist Centres have links to clinics, but all hospitals should have links to pain management clinics, I think.
So not all hospitals will have a pain clinic, and not all pain centres have a specialist in pelvic pain. So if they don't necessarily have one within their service, then because we have a good national network, they should be able to direct, the individual pain clinic should be able to direct patients elsewhere.
That's great, thank you. Arif, and I'm going to ask you one last question before I hand over to Hannah, which is, Amir's asking, do pain centres ever overlap treatment with therapies like acupuncture? Is that something that you would ever consider?
So acupuncture has been widely used. Recently, however, the funding has been withdrawn based on a nice interpretation that in the context of musculoskeletal pain, acupuncture is not a maintained effect over a long period of time. Now, generally, when patients are seen by the pain specialist physiotherapist, many of whom are trained in acupuncture, they may use that if there are some individual areas of trigger points as a short-term measure, combined with a large number of other strategies. So it's not a definite no, but often when, partly because of the primary care trust had removed the funding, if people are referred purely for acupuncture, that's often not agreed, but as part of a combination of treatments, it can be facilitated.
Thank you, Arif. Now, there are still lots of outstanding questions, but Arif has very kindly said that he will do more detail on this at a later date. I'm sure you're busy, but we appreciate that, and we'll schedule that again. So I'm actually going to move on to Hannah. Hannah, can I hand over to you, please?
Absolutely, thank you. So I think I should be sharing my screen very shortly. Can you hear me okay?
Yep, that's great. We've got your screen, thank you.
Perfect, okay. So physiotherapy in the management of endometriosis. For those who joined us at the last information day, I'm sure you have a fairly good idea about the work that the pelvic health physios do, but for the interest of new faces here this evening, I think it would be good to recap on who we are and what we do. So pelvic health physios have specialised in the assessment and treatment of women with common bladder, bowel and pelvic pain symptoms, not necessarily caused by endometriosis, but often associated with endo. We must also remember that these symptoms can be influenced by many other factors, such as age or childbearing status or daily activities or BMI, for instance. But this evening, we'll run through the common bladder, bowel and pelvic pain symptoms and some general advice for these that you can try at home. So many ladies come to us with feelings of real urgency and needing to pass urine, or leaking en route to the bathroom, or going to the loo a lot more than their friends, as well as struggling to empty their bladder completely, or even experiencing bladder pain as their bladder fills up. There are a number of different reasons that this could be happening. So let's explore a couple of those reasons, and potentially they might be things that you can adjust at home if you are experiencing these symptoms. So things that can aggravate your bladder, which will make the urge to go much stronger and the need to go potentially more frequent, things like caffeine, citrus, alcohol, spicy foods, and concentrated urine. So for those out there who are potentially experiencing urgency symptoms, who think that reducing their fluids will help, you could actually be making things worse. So something there to bear in mind. Another reason for these sorts of symptoms could be weak or tight pelvic floor muscles, and this is something that we'll talk a little bit more about later. Another potential reason is what we call as physios drinking in clusters. So that's when you've perhaps done, had a busy morning, forgotten to drink in the last 4 hours, and then you've knocked back half a litre thinking that that will do the job. But actually, that's a little bit of an insult to the bladder to have to process that fluid quite quickly. And so we do encourage ladies to steady out their fluids between sort of 100, 150 mils an hour, little and often being the key feature here. Another reason might be not peeing enough, or potentially peeing too much. So it's normal to pass urine between 6 and 8 times daily, which is approximately every 3 to 4 hours, not including nighttime, of course. So if you are finding that you are going to the loo far less than that or far more than that, that's something that may need addressing. And if it's not something you can manage by yourself, definitely get a referral to a pelvic health physio who can definitely help you with that. And for ladies struggling to empty their bladder, there are some techniques that you could consider to help with that. So first and foremost, take your time on the toilet and relax. I think so many of us try to rush because we've got better things to be doing, and actually that can be half the issue. So take your time, relax the pelvic floor muscles, really let go underneath, and imagine everything just descending down slightly towards the floor, but without pushing. You can lean forwards and pop your elbows onto your knees and just wait there for about 20 seconds and allow that bladder to adjust to the new position. You may find rocking forwards and backwards on your on the toilet, just with the pelvis rocking forwards and backwards. You may find that a little bit more urine comes out at that point, or even standing up, shaking your bottom slightly and sitting back down usually does the trick. So it can just be a positional difference in your bladder that just needs a little bit of movement in order to get the last bit out without pushing. So like bladder symptoms, bowel symptoms can be equally debilitating and embarrassing. So let's go through some of the helpful tips that you can give a go at home to address many different bowel symptoms. So first one, as you can see in the picture here, is the correct position to sit on the toilet. So sitting with your knees elevated when you open your bowels. This opens up the back passage and can reduce straining. Use a step as demonstrated here in the picture, or even a few books or magazines under your feet. As long as you can comfortably place your weight through them, then that's absolutely fine. And leaning forwards there again with the elbows on the knees can be useful, allowing that tummy area and the abdominals to really relax between your two legs, and letting that go can help an awful lot. The next bit of advice I have for bowel symptoms would be getting your stool type right. I know this is a bit of an embarrassing topic, but if no one else can talk about it, the physios can. It's really important to get this bit right, because if it's too firm, then you're going to perhaps end up with a picture of constipation. And if it's too loose, it can become very difficult to control. And we know that stools vary in shape and size, and the aim is to get a stool that looks a little bit like a sausage with minimal cracks on the surface. There we go, embarrassing bit over. It should be comfortable to pass. But if you are experiencing pain when you're passing stools, you know, this will cause the anal muscles to tighten up in response to that pain, which can inhibit the movement of stool further. So if you are experiencing pain and troubles emptying your bowel, do again get a referral to a pelvic health physio, and we can really review this and see what potential features are affecting your ability to pass stool comfortably. The next bit of advice would be being aware of your diet. I know that this is spoken about an awful lot, and there's a hell of a lot of information out there. This does vary person to person. Everyone responds differently to foods. For some, increasing fibre and fluid would help constipation. For others, foods like garlic or onions can play havoc with their bowels and lead to loose, uncontrollable stools. So my advice is make a list of all the foods you most commonly eat. Try 1 to 2 weeks without one of those foods. If it doesn't make a difference, reintroduce it back into your diet and choose another item of food to eliminate, and do it that way. If you eliminate all types of food groups, you don't actually know which individual item is causing the problem or not. So I tend to find this sort of elimination diet of one food at a time usually helps you kind of really identify and hone in on what the problematic food is. And finally, for this section, I would say try a probiotic. There is evidence out there to support them. I do have lots of patients that anecdotally do benefit from having a probiotic. There's lots on the market, they vary in price, so find one that suits your budget and discuss with your doctor and pharmacist if you're concerned about the interactions with other medications. So here we have some of the most common pelvic pain symptoms that we see as pelvic health physios. It's important for us to understand what the triggers are, if they're there all the time, do they fluctuate, do they depend on activity such as, you know, getting pain when you sit down for long periods of time, or cycling, or during sexual intercourse. This information is really helpful to us as physios to help guide treatment. Vulvodynia and vaginismus are listed here as some of the most common forms of pelvic pain that we do see. So pain around the vulva and spontaneous contraction of those pelvic floor muscles, potentially on contact. So let's talk a little bit through sort of why these symptoms do arise in many cases. And the best way to describe this, and I simplify things a little bit just to really help us all to understand, when you get stressed or anxious or scared or even in pain, what tends to happen to your muscles or your body? They tighten up and they tense. Is the simple answer. So it's not surprising that women experiencing either stressful situations or high anxiety or high levels of pain tend to develop overactive muscles, not only in the pelvic floor muscles, but also around the abdominal area as well, without them necessarily being aware. And we know that muscles are designed to contract and to let go. That's how they operate, and that's how they're functional. So when you have a muscle that's contracted and tight, it's not doing what it was designed to do, and therefore it can become sore and uncomfortable, and this can lead to further, more widespread pain that ultimately we want to avoid. When we're stressed and tense, I tend to ask patients what things make us feel better. Maybe it's a bit of mindfulness, maybe it's some relaxing music and a warm bath. And for others, it might be a massage over that particular area that's uncomfortable. And similar things can make a difference for pelvic pain as well. So let's focus on massage in this instance, as massage essentially increases blood flow and circulation. It breaks down adhesions, that scar tissue and those sticky bits within muscles, and ultimately it lengthens the muscles and their fibers. And this is something you can easily do at home, especially if you can't be accessing some pelvic health physiotherapy services at the moment. And whether it's over your abdominal area or whether it's in the pelvic floor muscles, there aren't really any strict rules. I think we get a little bit frightened about what we can and can't do. And a lot of it is actually quite instinctive. The key thing is find the uncomfortable point, apply some pressure over that area, and then try some small circular motions and see if the pain starts to reduce. When it does, move on to the next point and continue that way. We'll see how we can get onto the specific points within the pelvic floor muscles in a moment. So that moves us on to a little bit about if you were to come to a physiotherapy appointment pre-COVID, we do a big assessment and we also offer treatment. At the moment, we are doing a lot of virtual appointments, so over video or even over the telephone, and we haven't yet gone back to face-to-face just yet, but I'm hoping it will be something we can bring back in sooner rather than later. So in terms of assessment, any pelvic health appointment will include a full assessment, usually asking you lots of questions about your symptoms, an examination of your abdominals and the general pelvis area, and usually a pelvic floor examination, which could be vaginally or through the back passage, depending what your symptoms are. Treatment usually includes lots of education, pelvic stretches, which we're going to explore in a video in a moment that has been pre-recorded, a little Blue Peter moment for you all. Pelvic floor exercises and relaxation, manual therapy techniques, usually to help reduce sensitivity, perhaps some TENS or acupuncture, and absolutely agree with Arif here that TENS and acupuncture is used very commonly as an adjunct to other therapies, not usually in isolation. And I do personally do acupuncture and find some pretty good results, all dependent on the individual, and it will be assessed on a case-by-case basis. I do find that as long as the patient is being compliant with many other of the treatments, that acupuncture then acts as a good add-on. We go through mindfulness and breathing techniques and sort of signpost patients to specific resources for those, fluid and diet advice, as we've mentioned previously, and potentially some bladder training depending on the symptoms of the individual. So pelvic floor muscles, we do love to go on about these. I am aware as a pelvic health physio, I talk about these probably 90% of the time, but they are actually, I think they're fairly, the center of the universe, really. They're sort of responsible for an awful lot. So they are a hammock of muscle that stems and is connected to both the pubic bone and the coccyx bone, which you can see in the image here, which is the very bottom of the spine. And it's the red hammock there. It supports your bladder, uterus, and your bowel. So very good supportive role there. Also has a huge role with sexual pleasure as well. So something to bear in mind. I do describe these muscles as emotionally driven muscles. They are commonly tight in patients that are experiencing high levels of pain. And as we've mentioned in the previous slides, when we are feeling stressed or anxious, it's normally those muscles that kick in as a little bit of a support network. And they usually do kick in without us always being aware. We do find that tight muscles tends to equal weakness. We mentioned earlier that muscles are designed to contract and to let go and to move through their full range of movement. So when they're tight and in one shortened position, they tend not to be able to move through their range of movement, and as a result, we can experience weakness. The combination of tightness and weakness can lead to more pain and potentially some continence symptoms as well. I've popped two pictures on the slide here of common devices that we use, or dilators. There are many out there, many to choose from. These are just a couple of examples that we use to help ladies find those trigger points or those areas of soreness within the pelvic floor and the muscles within there, to apply pressure and to create small oscillating or circular motions over that area to try to release those tension points. They range in different sizes depending on what you're happy with, and you can build up. I use them a lot with ladies experiencing sexual pain to help improve confidence as well in terms of size. So lots of them out there, and definitely worth considering. If you do feel a little bit apprehensive about using these devices, I tend to advise, imagine lying on your back and your vagina is like a clock face. So up at the top of the pubic bone where your clitoris is 12 o'clock, and your back passage or your anus is at 6 o'clock. When you insert any device, if you aim either side of 6 o'clock, so that's your 5 o'clock or your 7 o'clock, if you slide the device in on those angles, it tends to be less sensitive, and you work in the region of 7 up to 9 o'clock, and on the flip side 3 to 5 o'clock. And that way you're just working on those soft tissue muscle structures and not creating too much pressure over the bowel or over the bladder. So this brings us on to a little video that I created on pelvic stretches. So I'm hoping that you can all see this and it doesn't stop and start. And we're going to go through some common pelvic stretches just to help release the muscles around the general pelvis, but also the fascia, that's the connective tissue that feeds into the pelvic floor muscles underneath as well. This knee to chest exercise is really simple to do, and you're just ensuring that you're really lengthening that lengthened leg along the floor, and holding that stretch primarily, well, you should really aim for about 40-45 seconds for each side of the stretch that you do. This glute stretch is absolutely fantastic. It can be a little bit intense, so take your time with it, and just pull as far as you feel that you can. The stretch you'll feel should be more intense in this image, the left hand side of the bent leg, in the buttock on that side, bringing us to knee over shoulder. So again, this is focusing on the glute muscles, the back of the pelvis, and just gently drawing the leg over to feel that stretch in the outside glute muscles there. Again, holding for that sort of 40 seconds or so. This one's a little bit more of an extended stretch. It goes into the lower spine, which is a really a good one for loosening up that lower back. Just be sure to really draw in your abdominal muscles and those pelvic floor muscles as you do any of these exercises, just to support that lower back throughout the exercise. And bringing us into a child's pose. So really, again, here thinking about allowing your tummy to relax down to the floor and try to keep your body as relaxed as possible and just enjoy that stretch. This is the flat frog rather. So this one, just as the legs slowly drop out to the side, you're just letting gravity pull those down, and you should feel a good stretch on the inside of the thighs. This is the happy baby. This can be a really intense stretch actually, or at least I find that it is. So again, take your time with this one. You may need to pop your legs up on a wall in the first instance, and then work up to being able to hold with your hands. And the relaxed frog is as it looks really, and you're just aiming to get your elbows on the inner parts of your knees, and just you can gently press back on the insides of those legs there to open up the pelvis a little bit wider to improve that stretch. So I think I might just be on time, and any questions, what I'll do is I'll bring up my video so that I can how do I do that? Bear with us here. Let me see here, stop sharing, great, and start video. So hopefully you'll be able to, there we are, see me, and if there are any questions, very happy to answer them. Thanks for listening.
Hannah, that was excellent and very informative. I think we're going to get some requests for you to also do some more on this one, I think. We've got a few questions and you're perfectly on time. And so one thing is requests to people to know how can they get referred to pelvic physiotherapy?
I know. It's a little bit of a limited resource actually, which is such a shame. There's about 800 of us in the UK and not a huge amount of us in London, but perhaps more centralised in London as opposed to surrounding areas. So it's at the moment at the Royal Free, we accept Camden GP referrals and Royal Free consultant referrals only. That's all we have funding for. But every trust is different, and I know that Imperial and Chelsea and Westminster have very different catchment areas. So I think it's a case of speaking to your GP, and hopefully they will have links with the relative trust that could accept your referral.
Great. A lot of people are asking if they can have the video, and Hannah has very kindly said that we can circulate that afterwards, and we'll also be circulating the webinar, so yes, you will get to see that one. I know, just so you know, and I find it shocking that we don't have more pelvic physios, and it's one of our campaigns to try and get more people to access them, I know. And so one of the other questions is people, I don't know if this is something I might follow up with you, Hannah, but people are saying, I can't get physio, or I'm waiting for physio, pelvic physio. Is there any places I can look online? So maybe we could see if you could recommend some places. I don't know that we could do that.
Within the NHS or privately, or?
Well, yeah, NHS ideally, I think, but we'll have a look at that afterwards.
So I think we have a really long waiting list at the moment, and it's one of my daily headaches, and we are looking to really get that down as much as we can. We currently have a 5-month wait list, which is just not acceptable, and I'm sure many trusts are under the same sort of a panic with this. So it is something we are working on. There are lots of resources out there. Instagram is brilliant. There's some brilliant physios out there, and I can give links for your website that people can access that sort of social media and following, and yeah, any other websites that we link into. The POGB, the Pelvic Obstetric Gynecology Physiotherapy Specialist Interest Group online. They're fantastic. They've got great leaflets. I'll give you
name.
Yeah, it is, isn't it? Gosh. And we'll give you all the details for that, so you can pop that on the website too for everyone to access.
We will do, and we'll send that out to everyone who's attended so that we can get that details. And one last question, because we're almost out of time, is how often should people be doing those stretches that you showed?
Question. I tend to say, well, because we know it's about 40-45 seconds per stretch per side, you could be there all morning. Choose your 3 or 4 favourite ones, the ones that you really feel hit the spot, and do those daily. And I think once you're at a point where pelvic pain is better managed, then you can work to doing it twice a week as a maintenance program. But in the initial stages, I would say daily, because that input's good for the muscles and all the sensitivity around the area.
That's great. Now, thank you everyone. I don't know if all the other speakers want to come back online so we can see everybody. We are at the end of our session. A massive thank you to the team at the Royal Free. You're always fab. The Living with Endometriosis Day was great, and that was really informative, and thank you so much for that. We haven't been able to answer everybody's questions. We've got through a lot, and so we will try and follow those up. We'll be back in touch with people who were on the webinar, and we can also try and follow up with other events as well afterwards. I don't know if Fevzi, if there's anything you want to add before we say goodbye to the night.
No, I just wanted to say thank you for everyone. It's always informative, these sessions, and I learn from them as well, and hope that people found it useful as much as we all did. And like you said, with the questions, we'll try and address some more if we can by some other means. We'll talk about that afterwards and see what we can do to answer the ones we didn't get an opportunity to do so.
Great. Well, thank you, Fevzi, Arif, Hannah, Gonzalo and Nicola. Very many thanks to all of you for joining us, and I hope we see you at an event like this soon. And we'll certainly be following up with Arif, Hannah, and I'm sure Fevzi to see if they'll help us with more events in the future. Thank you very much, everybody.
Pleasure. Thank you.
Thank you.